Welcome to the Lifestar EMS Training and Education Center. My name is Todd and I'm glad you joined me today. The topic for this discussion is going to be 100 milligrams of Lidocaine rapid IV push, please. This is a 911 call that happened in another county and I am engaging in forensic paramedicine. What I'm doing is reconstructing what happened on the call by taking a look at the code summary and putting together all available evidence to figure out what was going on with the patient, what was going on in the mind of the paramedic, and trying to figure out what happened and why. It's kind of a little detective work. I love doing this stuff. It's a problem-solving exercise, and I really learn a lot by going over this kind of information and filling in the blanks. You'll notice the subtitle here is Panic and Tunnel Vision in the Emergency Medical Setting. So there's a little bit of drama involved in the call too, which is always entertaining. So this is a call that happened in October of 2013. I happened to be listening to the radio at the time, so I heard the call unfold as it was happening. And then I obtained the code summary to kind of put the pieces together after the fact as well and reconstruct. This is a 911 call in a paid-on-call fire department. It's an ALS department, paramedic level, and the call is for weakness. While on scene, you can hear one of the EMTs get on the radio to the local hospital, and they issue a stroke alert. And then the fire department began transporting the patient. They did go lights and sirens, which is department policy for any suspected stroke. And then you hear the paramedic get on the radio in the back. You can hear the sirens going, and the paramedic calls the hospital and asks for online medical direction. So the call for medical direction begins with requesting the hospital's attention, and you hear a female voice get on the radio and say, "Go ahead with your request," and the paramedic says, "I need to speak to the doc." A couple seconds go by, and then you hear a female voice, may or may not have been the same person, say, "Go ahead with your question." And then the paramedic, in a very sarcastic tone of voice, says, "Are you the doc?" And that's when I turned up the volume of the radio because I wanted to hear how the rest of this conversation was going to go. So the voice says, "Yes, go ahead with your question. This is Dr. So-and-so." And the paramedic says, "Did you get my 12 lead? Did you get my 12 lead?" Just that tone of voice and with that much of a pause between. So there's a little bit of silence coming from the hospital, and then you hear the doctor say, "I got what you sent me. Go ahead with your question." That's going to be an important clue to what's going on with this call. So the paramedic then says, "We have this patient that we thought was a stroke alert, and I'm looking at the cardiac rhythm, and I'm seeing several extended runs of wide QRS complexes. I would like to give 100 milligrams of Lidocaine rapid IV push for ventricular irritability." You hear a few seconds go by, and then the doctor answers, "No, let's not give the Lidocaine right now." And the paramedic then gets on the radio and says, "Okay, so it's okay to go ahead and give the Lidocaine?" And then the doc, in a very exasperated voice, says, "No, don't do anything else to this patient. Just bring her here." And that was the end of the conversation. So I really wanted to see what the paramedic was seeing on the monitor to figure out why 100 milligrams of Lidocaine rapid IV push would be appropriate. Here we see Lidocaine in the standard pre-filled syringe. It's 100 milligrams, which is an easy dose. The dose for Lidocaine for the non-ALS people is 1 to 1.5 milligrams per kilogram. Generally, it's for malignant PVCs and ventricular irritability. But the paramedic is talking about several extended runs of wide QRS complexes, very much making a case for ventricular tachycardia, or VTAC. And the paramedic is asking for rapid IV push. Paramedics generally are cautious about giving Lidocaine because Lidocaine, as you know, can reduce the sensitivity when it's a numbing agent when it's used topically. It's what the dentist injects into your gums in order to work on your teeth to kill pain. And it does the same thing to the heart. So when you're going to give a medication to numb the heart, you want to be careful about that. And some of us have had the experience when you give lidocaine that the heart rhythm changes. And you also have the experience sometimes the patient will begin to crash. So we generally give it slowly so you can turn it off, and we'll give it in a piggyback setup. And you see a piggyback here in which you would have on the left maybe a liter of normal saline running, and on the right you would have the lidocaine running. And if anything happens, you can immediately shut off the lidocaine and turn up the saline in order to bring pressure back up. It's just a good cautious way to give it. 100 milligrams of lidocaine rapid IV push is an incredibly aggressive and reckless way of giving lidocaine to a patient that's experiencing a cardiac event. So let's take a look at the code summary and see what we can learn forensically after the fact. So here we see a patient that's 79 years old and female, and I circled the pressures over on the right, 143 over 107 with a heart rate of 78, and down in the lower right, 137 over 54 with a heart rate of 96. So this right at the moment, based only on this evidence, is presenting as a patient that appears to be hemodynamically stable at the moment. So here we see at 2134 the initial rhythm. That's when they first put the 4 EKG electrodes on the patient, the first rhythm that's analyzed by the monitor. It generally will gather an 8-second strip immediately after the electrodes have been applied. This, by the way, is a Lifepak 15 monitor, which is good to know because we understand some of the characteristics of the Lifepak 15 and what it does and why it does what it's doing. Down here we see the first 12 lead at 2137, so that's only 3 minutes after the initial rhythm is obtained. Someone pressed the 12 lead button. Down here we see that whatever that 12 lead looked like was transmitted to the hospital at 2140, 3 minutes later. And then we see that we have at least 3 more 12 lead attempts, one at 2141, one at 2145, and one at 2148. So we're getting sequential 12 leads just a few minutes apart for some reason. And if we go to the second part of the code summary, you'll see we do have one more pressure of 154 over 125. Diastolic's probably a little suspicious there. And then a 5th attempt at a 12 lead. So that's 5 12 lead attempts in about a 20-minute period. Let's take a look at the code summary from beginning to end. There was certainly a lot of information in that code summary, and I left the code summary intact so you could see that nothing was edited out of it. So did you catch what was missing from that code summary? If you did, well done. You might have noticed that there were no 12 leads anywhere in that code summary, although we know there were 5 attempts at obtaining a 12 lead. That's an important clue as to what was going on in the back of that ambulance. It also explains why there was miscommunication with the hospital. And most importantly, it shows that the paramedic didn't have all the information he should have had at his disposal. Let's find out why that happened. So we noted that no 12 leads appeared, and if you look at the box at the bottom, you'll notice that the ECG override function on a Lifepak 15 says when you try and get a 12 lead, if there's a lot of noise or excessive data, it's going to not run the 12 lead, and it's going to give a warning to the user. It's going to say noisy data, press 12 lead to accept. And that message will remain until one of two things happens. It'll remain until all the noise goes away and it can get a good clean 12 lead, and then it'll go ahead and take that 12 lead. Or if the paramedic wants that 12 lead right away and is willing to tolerate whatever artifact or noise is going on, you can press 12 lead button again and it'll run that 12 lead for you. If neither one of those two things happen, at the bottom it explains that if the signal noise persists for longer than 30 seconds, it's going to give up on getting that 12 lead. The screen will say excessive noise, 12 lead cancel, and then you have to start all over again in order to get that 12 lead. So this is the initial rhythm that was obtained at 21:34. In the upper left I circled lead 2, so that's the lead that we're looking at, and that is just kind of an ugly, disorganized rhythm. You're not really entirely sure what's going on. At the tail end, you're seeing some wide QRS complexes that look a little bit like a left bundle branch block, and so that ST segment elevation over there, it actually, if you apply Smith and Scarbosa criteria, might be STEMI, but it would need, this is non-diagnostic, this is only lead 2, so you can't scream STEMI just yet. In fact, it's never going to be a STEMI, so you can take that off of your index of suspicion. But this is the initial rhythm. So as soon as those 4 wires were put on the patient, there's an 8-second strip that the Lifepak prints out to show what the first look at cardiac activity is. The next thing in the code summary is a print, and the print at the top there means that the paramedic pressed the print button. And on a Lifepak 15, when you press the print button, it'll capture whatever was going on for 3 seconds before you press the button, and then for 5 seconds after you press the button, in order to capture whatever it is the paramedic was trying to capture. So there in lead 2, we're seeing some different morphologies. Morphology meaning, of course, the shape of the ECG. You're seeing different morphologies going on here. You got this kind of ugly, disorganized stuff in the very first circle, and then you see kind of a left bundle branch thing happening, or a PVC thing happening in the second circle. And then the third, you see a regular morphology, 3 of them in a row, that looks kind of like that left bundle branch kind of thing going. And then you go into kind of a very disorganized, ugly rhythm. And then at the very tail end, it almost looks like you got some 60 hertz interference with some ugly stuff happening after it. Definitely a what is going on here kind of situation. So in this next box, we have a check patient. On a Lifepak 15, if it sees a dramatic change in the cardiac rhythm, it prints out a check patient strip, which is 8 seconds of whatever it was seeing immediately prior to the check patient. So whatever this rhythm is, the Lifepak wants to bring it to the attention of whoever's in the back of the ambulance and say, hey, look, what we've been looking at is very different from what we're seeing now. You should take a look at this. And check patient is also an indication that maybe you need to check for a pulse, because this may be a pulseless rhythm. The next box is another check patient, so something happened in this rhythm that caused the monitor to want the paramedic to take a look at the patient, make sure the patient still has a pulse, and then also there's something different going on in this 8-second strip that the monitor wanted to bring to the attention of the paramedic. And I'm going to indicate here, I'm going to give you a second to stare and see if you can figure out what it is the monitor wanted the paramedic to see. If you look at this strip again, you'll notice something new has entered into this whole equation. we see some arrows. Those arrows are how the Lifepak indicates that there are pacer spikes happening somewhere in the rhythm. They're very occasional. It could be artifact, it could be road noise, but it looks to the monitor like a pacer has started firing, and it's firing in a very inconsistent way. You have one firing about 3 seconds in, and then about 6 seconds in, you have this double bang on the pacemaker. Just kind of weird, and it might be something that you choose to just kind of wait and see if it happens again, because it's not a very reliable, just a few blips here. But that is the reason why the monitor wants to get the attention of the paramedic. So now we have another check patient. It's 2142 now into the call. Now we're seeing some more frequent firing of those pacer spikes. So now you're beginning to suspect that there's something going on here. We're not really seeing changes too much in the morphology of the rhythm. It's still in lead 2 an ugly wide QRS complex rhythm. It's predominantly negative in its deflection. It's below the isoelectric line, but you got some weird stuff happening here, and it's definitely should be raising some eyebrows about trying to figure out what is going on with this call and what is going on with this patient. So here, it's not a check patient, it's a print function. So print again is 3 seconds before the paramedic pressed the button and 5 seconds after. So you're looking at the screen here and thinking, what is it the paramedic saw that caused him or her to press this print button to try and capture whatever's going on in the monitor? Remember, you're looking at the monitor screen, you're not looking at the paper. And printing is to capture what you're seeing on the screen. So here we see, I just put a big arrow to show one of the morphologies that's going on. But look at the bottom with the pacing spikes. Now the pacer is firing much more frequently, and the result is a very even, consistent morphology of a ECG, a QRS complex here. It's a wide QRS. Probably doesn't meet Smith and Scarbosa criteria. Again, it's not diagnostic. You have to do an actual 12 lead to talk about the ST segment. But this is very much looking like a paced rhythm, right? We've all seen that on the monitor. It's wide QRS complexes. There's usually a rebound where the ST segment is far above the line. Because of that rebound, the QRS dips so far down that when it comes back, it rebounds high. And this is what the paramedic was looking at on the screen that he was trying to capture. This is also about the time that the paramedic called in asking to give 100 of Lidocaine rapid IV push. Again, though, what is the paramedic actually looking at? Is he looking at the printout, or is he looking at the screen? Just knowing how I work with monitors and how other people work with monitors, when you're just pressing print, you're usually not pressing print in order to look immediately at the paper. You're just trying to capture that for the record of whatever it is you're seeing on the screen. So now we have another print, again 3 seconds before and 5 seconds after pressing the print button. That little down arrow shows exactly when the button was printed. And here I'm pointing out different morphologies of rhythm. So this may be what the paramedic was trying to capture, was the change in rhythm. And then it goes back to that paced rhythm again. So for a while we have these weird, ugly, low voltage QRS complexes followed by a nice, big, consistent paced rhythm. And again, you see the pacer spikes indicated at the bottom of the printout. Here's another print pushed by the paramedic 3 seconds before and 5 seconds after. You have pacer spikes. They're kind of uneven at the bottom, but then you have mostly this wide QRS complex, typical paced rhythm. Here's another manual print pressed by the paramedic, and again you have wide complex QRS and lots of pacer spikes at the bottom, very irregularly placed. So let's really dig in and analyze what was happening on this call. So first of all, on this call, no 12 leads were actually performed. The button was pressed a number of times, but because of the tunnel vision and not paying attention to the monitor, no 12 leads were actually obtained. And since no 12 leads were performed, no 12 leads were transmitted. That kind of explains the confusion in calling medical control and asking, did you get my 12 lead? And the doc having to look around and figure out, first of all, did they send a 12 lead? Or the second question might be, why doesn't this paramedic realize what I'm looking at is not a 12 lead? So there was the delay in the doctor's response, and then the irritation on the part of the paramedic, which clearly was not justified. Pressing print could have provided a clue of pacer spikes, but the paramedic actually has to look at the printout. And as I said before, frequently when we press just print because we're looking at the screen and seeing a rhythm, all we're trying to do is capture this on paper for later reference, and we're not really planning on taking that printout and looking at it immediately. Had the 12 lead been done, then the behavior of the paramedic usually changes, because when you have a 12 lead, you want to rip that 12 lead off and actually interpret it, and then the pacer spikes would have been evident, and hopefully this paramedic would have seen the pacer spikes and maybe put two and two together as to what's going on with these QRS complexes. But because we didn't have those pacer spikes, the paramedic misinterpreted this rhythm as VTAC, and seeing VTAC on the monitor is kind of one of those oh my goodness moments. And again, we had tunnel vision. Paramedic decided what was going on with this patient and didn't look at all the available evidence, and also didn't ask the question, am I right in my conclusion? And good paramedics aren't necessarily the aggressive ones that choose the most advanced treatments. Good paramedics are the ones that question their decision making and reevaluate what's going on while the patient is still in the ambulance. The treatment guidelines would have called for 150 milligrams of amiodarone over 10 minutes for a stable VTAC, but this paramedic was asking for the more exotic or more aggressive treatment of 100 milligrams of lidocaine, and not just 100 milligrams of lidocaine, but as a rapid IV push. So, what was wrong with this patient? Looking at the preponderance of evidence, the chief complaint of weakness, and the initial rhythms with that weird native beat, and then the changes in rhythms and the coming and going of the pacer spikes, the most likely explanation is there's something going on with the cardiac pacer. And in fact, a follow-up with the hospital did reveal that this was a patient whose pacer was failing to capture electrically, and it was failing to fire altogether. And so the patient was sent up to the OR and they replaced her pacemaker, and the problem was solved. So I would leave you with this very important question that this paramedic will never know, because I don't know if the paramedic ever followed up and learned what was wrong with the patient. But what would have happened if 100 milligrams of lidocaine were given rapid IV push to a patient whose native rhythm looks like this? I'd like to thank you for joining me. This is the Lifepak Training and Education Center. My name is Todd, and I look forward to seeing you the next time.